Hi, everyone. This is Pam Gibson at James Madison University, and I wanted to talk to you a little bit today about unmet medical care needs in persons with chemical sensitivity. So I'm going to share my screen here. And this, I know I say this every time, but this is one of my favorite studies because we looked at what people said happened to them when they tried to get medical care for chemical sensitivity. We used grounded theory in order to study what they said. And grounded theory is a way of building up a theory from what people say. You look at every word people say, you start with very small analyses of small phrases, and you build them together until you have something that has been built from your particular study. It's not exactly objective. You can have different researchers study the same topic and get different themes, but they're called categories actually in grounded theory. But what we did was interviewed 19 people, 14 were women, with self-reported chemical sensitivities in order to study the medical care access and use for that population. We analyzed the interviews using the grounded theory in the tradition of Glasser via incident-focused and theoretical coding. We named our core category Health Quest, meaning resisting annihilation is what they were really trying to describe. And we construed 4 categories that embody the essence of this quest: illness as omnipotent, bidding for access, standard protocols irrelevant, and transcending hegemony. I'll talk about each of these categories so as not to make this too long, just give you a snapshot and use a lot of visuals to show you what we found. As part of a larger survey study of unmet medical needs, we interviewed these 19 people, 14 female, who self-identified with chemical intolerance. Respondents were a mean age of 50.7 and had been chemically sensitive for a mean of 19 years. The phone interviews lasted 30 to 45 minutes and were then transcribed and coded via the incident-focused and theoretical coding. In the last few interviews, we, quote, interrogated our categories. That is, we looked at the categories in people that lived in somewhat different circumstances to see if they would hold up across a variety of lifestyles, etc. And we found that it did not alter our categories, so it did hold up. So here's a visual of the whole study. Our core value is people are just trying to survive. We named it Health Quest, resisting annihilation, because everything is coming at you. And the categories that fed into this, that comprised this, included illness as omnipotent, and I'll talk about each of these in a minute. Oops, sorry, I didn't mean to do that. Category 2, bidding for access. This is where you're asking for help. Category 3, standard protocol irrelevant. This is when you go and you try to find someone who can help you medically and they don't have any tools. And category 4 is transcending hegemony, avoiding annihilation. So let's look at these. I know this is a little daunting when you first look at it. Here is category 1, illness as omnipotent. When people start to realize that something's going on with them, some people take a long time to figure it out. Some people figure it out sooner. Some people are lucky enough to get diagnosed actually, but they're getting more and more restriction of their personal potential here. They start to realize what the heck's going on, and they start to realize that they're going to have a rough life. Things are not going to be easy for them. Some people have life-threatening reactions. Some people have constant symptoms. Some people know people who have died from MCS. So it's kind of being hit by something big. They fear some of the exposures because some of them are pretty scary. They can range from anything from mild to life-threatening. And so this makes you very vigilant. So there's the vigilance up above. You have diminishing access. You're really losing access to a lot of different kinds of places: medical care, school, grocery stores, friends' houses, sometimes even your own house. Your resources may be dwindling. If you lost your job, if you can't work as much, you're going to have less resources to work with. We called this part of the category struggling with drastic change. And part of that is restriction of your personal potential. You can't reach your potential in your job. You can't maybe work with the art supplies you worked with. There's a lot you can't do. Many people struggle with the isolation, and with worsening symptoms and pain leads to yet more isolation because you can go even less places. And so when you put this one all together, it's kind of like being hit with a big brick on the head. And we figured that that all fed into potential desperation. So that's category 1. You realize that you're sick. Category 2, we named bidding for access. And some of the corollaries of this one are seeking providers. That's often the first thing people do when they realize that they're ill. I mean, here in the US, right, we're supposed to just go to a doctor and get well. So people start to seek providers. They call with questions. They call and ask about accessibility in offices. Sometimes they're lied to. Sometimes people just plain blow them off and lie. Sometimes people will not make accommodations for you to go. Sometimes the office isn't safe to begin with. It might have a gas stove. It might have been sprayed for pests recently. They might not be willing to limit fragrances. There might be a lot that you just can't expose yourself to. So you might end up being excluded and put into a group of irrelevant people. It depends who answers the phone, really, how you're treated. So this bidding for access doesn't always go well. You often need documentation for it, and so people will be seeking that, trying to figure that out. If you are lucky enough to get an appointment and you do think that the office might work for you, then there's the preparation for the appointment. A lot went into that. People talked a lot about preparing mentally, figuring out what they were going to say, because so many people are called psychosomatic. And so people are preparing what they're going to say. Some people felt anxious getting ready. Some people scheduled some downtime afterward. For example, we all know people who have gone to medical appointments and then spent 3 days in bed from the exposures. So they go through this preparation. Some people, even if there isn't an office that they might be accessible, that might be accessible to them, lack the resources, have no insurance. And so this process doesn't work the same for everyone. Some people can't be seen because they don't have enough money or they don't have the right insurance. So you're trying to find some help. So category 3, we labeled it standard protocols irrelevant, meaning lacking a medical paradigm. When you have something like this and you don't know what to do about it, sometimes you just walk into an office and tell people what's happening with you. Sometimes you are misdiagnosed. Sometimes you are seen as psychiatric. Sometimes you get unpredictable reactions from people. Sometimes you actually get support down here on the lower left. Some people actually did get some support. Sometimes you're blamed for your own problems. Sometimes you get disbelief. People just do not, just don't think this is possible. And sometimes you're just extruded or delegitimized. Now, if you do manage to get in, up here on top, we have treatment protocols forced upon the patient. If you don't have a tool for something, you might try to use a tool you already have. And so sometimes providers forced protocols on people that didn't work, or prescribed drugs that the person had already said they were allergic to, that kind of thing. Sometimes people endured harm from the treatment. And then this led to avoiding medical care in the future. And then you have those negative consequences of avoidance. You can avoid it for so long, but sometimes you absolutely need to go. So this is what often happens when they go for help. We call our 4th category transcending hegemony, avoiding annihilation. In other words, figuring out a way to survive. So one of the tricks here is maintaining your essential self in spite of a very difficult and poorly understood disability. People strove a lot to become self-sufficient. Some people felt empowered by this. They learned They educated themselves. They advocated for themselves. They took advantage of online support tools. Sometimes they went for medical help only in an emergency. And they started to see the world differently. They started to see MCS as a public environmental health issue. And some people sought alternative providers like holistic healers, holistic doctors, and some of them got substantial help, like real help. They began to avoid all exposures because they know that's the way that you get better. They cleaned up their home environment, and they trusted their own worldview. So that works for a while. The problem is, if you encounter an emergency, you can end up right back at category 1, bidding for access if your eyes open and you're in an emergency room and people ask you questions about yourself. So it's hard to become totally self-sufficient. Another thing that people did was they managed their disclosure. We call this disclosure destroys credibility. There are some providers for whom all they have to do is hear the word chemical sensitivity and they decide that you are a psychiatric case. And so some people told only trusted providers. Some people reported only the necessary symptoms in order to get help. For example, if you need help with a problem that has nothing to do with the sensitivities, you can, quote, play the game here, get your limited help and go home and not be disparaged by your provider. So what would we say the results are of this study? We named our core or central variable health quest, the behavioral drive for the participants. That's what the central variable is. The theoretical counterpart of which was attempting to resist annihilation. You're trying to survive. The 4 categories that comprised this quest were illness as omnipotent, bidding for access, standard protocols irrelevant, and transcending hegemony. So what did we learn from this? People with chemical sensitivity confront annihilation on a level of intensity not recognized by the general public. The medical care system teaches people that they can't depend on it. It teaches you right away, we're not going to help you. It silences people except when they are with safe others. Practitioners cause medical harm with their irrelevant protocols. They can cause harm. People attempt and succeed to some extent in using alternatives and avoiding conventional medical care. However, an emergency can put them right back at bidding for access. So in this sense, our categories can be seen as occurring temporally, like in a sequence. What can providers do? Even in the absence of an available treatment for the chemical sensitivity, providers can offer safe spaces for other medical needs. Providers can shepherd patients through medical procedures and help them avoid iatrogenic damage. Providers can help patients through medical use of medications and procedures by monitoring patients' reactions and thus offering safer treatment for the patient. But someone someday has to take responsibility for the fact that we have made millions of people sick by our constant and ubiquitous use of toxics. Understanding MCS in context means understanding that it is part of a world system in which greed is the driving force and the natural world is more and more quickly being destroyed. So I hope you'll see my research website at mcsresearch.net, and you can read my book for free or download it at the same site, or you can go to earthrivebooks.com. They both go to the same place. And you can see my other YouTube videos at my YouTube channel. And thank you so much for listening.